Thank you again for the invitation to be here. It's always an honor. So this is a little bit of an adventure because it's not straightforward at all. These are my disclosures. So the angiosome concept was actually come up with by plastic surgeons. It has to do with dividing up anatomically the lower extremity into different zones with the idea that wounds to whatever zone will heal better if the blood supply is direct versus indirect. Here's a map of the lower extremity and the territory covered by each of the three main arteries. And then, you should always pay attention to the arch of the foot as well, because if you're really going to go down this pathway and you're really going to revascularize somebody, you have to think about all the way to the toes. It's not good enough to think about things just to the level of the ankle. But the data is complicated. Endovascular, when you read the trials, you're not totally sure what that means. Is it balloons? Is it balloons and stents? Is it a combo? It just says endovascular. From an endovascular standpoint, though, you see in the data that it's a little bit easier to achieve direct flow, and I think that's because when you look at the surgical strategy, and we've got some great surgeons on the panel who I would love to hear comment afterwards, but I think, some of the difficulty with surgical strategy is just finding a vessel that's good enough to bypass, and who knows how easy or how challenging that can be. And then again, I think you have to extend things down into the pedal arch. It's very important, and it could affect your end results. So let's just break it down as quickly as we can. This is by no means an exhaustive search of the literature because we have a limited amount of time, but let's just look at endo and combined strategies. So these are plots that look at wound healing and limb salvage, and you can see by the studies that uniformly for wound healing favors direct revascularization, or in other words, the angiosome concept. And then below on the limb salvage graph, you also see that it does favor direct revascularization, which makes sense. I mean, if you think about it, it makes sense to try to get blood flow directly down into the area. This is a little bit more busy, but it just gives you an idea of the number of trials and how they're broken down, because the data is confusing. The level of study is somewhat questionable at times in terms of quality, but you see uniformly, if you take all of the studies, or you just look at endo, or you just look at bypass, you look at large studies, you look at propensity match studies, you look at follow-up, you still see uniform agreement that if you can achieve this, it does favor your wounds to heal. So now we get into some individual studies, and the reason why I bring this up is because, well, if it makes sense, then why are we even talking about this? Why wouldn't the answer just be yes and we just move on down the road? Well, the problem is you can't always achieve it. So when you start to look at these studies, and a lot of them are retrospective, you see the number of limbs and you see the number that were able to be revascularized in a direct fashion, and you find that you're on either side of the 50% mark most of the time. Now, when you can achieve it, again, freedom from limb events, freedom from amputation, amputation-free survival in these endo studies all favor direct revascularization. But in the previous study, 54% of the time they were able to achieve it. In this study, which is a great study, only 48% were able to have direct flow achieved. Again, if you could, your 12-month healing rate was 72% compared to 46%. So no doubt that it seems to be a better strategy. But how often is direct flow achieved? When you look at all of these studies sort of in combination, it comes out to about 54%. So not always achievable, but again, if you can, the numbers are great, even out to 2 years, and this is for limb salvage. So in summary, from an endovascular standpoint, you definitely have improvement in wound healing, but also in limb salvage. While there's no difference in mortality, these people are all still sick, so you can't fix that. And if you look at the numbers in terms of reintervention rates, they're anywhere from 15 to 33%, so fairly high reintervention rates. So turning to surgical revascularization, if you look at a couple of studies that I thought were pretty well done, the comparison between direct and indirect, you see on the left that the wounds heal. They heal quicker. They heal more complete. But on the right, you see a trend towards limb salvage that does not achieve significance. And this is borne out in another study where clearly the wounds heal. This is follow-up out to 5 years, 4 to 5 years, which is great. But in terms of what happens to the limb, you don't see much separation in the curves on the surgical side. So you take it a step further. So we've talked about the leg. Now let's just look at a study that not only looked at direct versus indirect, but started to look at what's going on in the foot. And so you see that if they had a complete pedal arch, they had good numbers for direct and indirect, because indirect can be okay through collaterals as well. Incomplete pedal arch type, still pretty good numbers, not much difference between the two strategies. And no pedal arch, it didn't matter how the blood flow got to the ankle. When they didn't have a pedal arch, things didn't turn out so well. And so when all of this stuff was compared, what you found was that the only statistically significant difference was between people who had a complete or incomplete arch, some form of arch versus no arch. Otherwise, there wasn't a real difference, and the wounds healed only if you had something patent. And that's where you have the influence of collaterals or choke vessels, where you have to sort of pay attention to how the blood flow is getting there, because again, in some of the studies, you'll see that indirect with good collaterals tend to heal nearly as well, if not as well, as people who had direct revascularization. I think that's where you add another level of complexity in terms of trying to tease out the data. So what about the pedal arch? The Rendezvous Registry looked at people who had pedal arch angioplasty. In CLI, you see that angiosome-guided therapy was achievable in 60% overall. In those who had successful or had pedal arch angioplasty, they also had successful angiosome-guided therapy 74% of the time. And this is what we're talking about, and it'll be discussed in a later lecture. So again, when you break it down, though, it all has to do with wound healing. There's no statistically significant difference in survival, limb salvage, amputation-free survival, or reintervention at 12 months. But you do see significant wound healing changes, earlier wound healing by about 140, 150 days. Take it a step further. So as a cardiologist, I like blush. I like the TIMI blush score. You open up an infarcted artery, you like to see that the ventricle is actually getting blood flow. So to me, wound blush makes sense. And if you look at these pictures, it does make sense. The one on the left that has blush looks a lot better than the one on the right that doesn't. If you look at this study, when they were able to achieve angiosome direct therapy, which was 61% of the time overall, but those who had wound blush positivity and had a good pedal arch, it was 68%. You see significant differences in favor of having wound blush, but also having achieved that direct flow. And this is another graph breaking it down at around 400 days. So you see a significant increase in wound healing. So in summary, the angiosome concept, you have to remember, is an anatomical, not physiologic. It was created by plastic surgeons to heal skin. The data is difficult because there's so many variables. There's no doubt that direct revascularization, according to this concept, leads to improved healing. However, I think limb salvage is probably still controversial. And that when you're thinking about direct flow, I think you need to think about it all the way down and through the pedal arch if possible. And so what I'm getting at is it should be the gold standard if you can achieve it. And this is a picture with multiple access. I think if you're really going to try to do a good job, then really try to do a good job. Sometimes you won't achieve it, but you should definitely give it your best effort. Thank you very much.